Hey, what's going on, guys? My name is Hunter White. I am a student at the DeVille School of Pharmacy, and today I'm going to go over my Journal Club 2. My Journal Club 2 I did on a study called Efficacy and Safety of Lemborexant in subjects with insomnia disorder who are receiving medications for depression or anxiety symptoms. So I chose this study because I have had insomnia for a while. I also concurrently deal with some depression symptoms. I found this study in the Neuropsychopharmacology reports published in 2025. The objective of the study was to evaluate the efficacy and safety of lemborexant in individuals with insomnia disorder who are concurrently taking medications for symptoms of depression or anxiety. So primary efficacy measures were changes from baseline in the subject sleep onset latency, SSOL, sleep efficiency, SSE, wake after sleep onset, SWASO, and total sleep time, STST. Two secondary measures, including insomnia severity index, ISI, and fatigue severity scale, FSS. So the study was a multi-center phase 3 randomized placebo-controlled double-blinded study. The subjects were all adults, so 18 and up, diagnosed with insomnia disorder. And all these diagnoses are going to be per DSM-5 criteria, who are also being treated for mild symptoms of depression or anxiety, and treatment being pharmacological treatment. So again, inclusion criteria were 18 and up, so adults, diagnosed with insomnia per DSM-5, must have an ISI score of over 15 at baseline, SOL must have been at least 30 minutes, and or WASO of at least 60 minutes, and this must have been for at least 3 days per week in the past 4 weeks prior to enrollment or baseline. Also, it must have stable depression or anxiety, which is managed with pharmacological treatment. And to go with that, the exclusion criteria is any unstable psychiatric condition, so being depression, anxiety, or any other psychiatric condition. Also, if you have a sleep disorder other than insomnia, if you have a Beck Depression Inventory 2 score of higher than 19, if you have a Beck Anxiety Inventory of greater than 15, if you're taking a CYP3A inhibitor or inducer, if you're taking a hypnotic or a stimulant besides caffeine. Caffeine was allowed the whole study. So the study was a total of 12 months. So this study was kind of unique because it was 12 months total, and it was kind of two things. So this is kind of a sub-study. So the main study looked at 903 subjects total. And it checked all of these, so SSOL, SWASO, STST, SSE, in all of these 903 patients. And then they went back into the study and refined it to just patients with depression and anxiety symptoms. So out of that 903, there were 61 subjects that had depression and insomnia. So that's where we get this subsection of the study. And this subsection kind of focused on 6 months out of that 12-month study. So monitoring, participants recorded daily electronic sleep diaries. This was assessed at baseline every night during the first 7 nights, and then at 1, 3, and 6 months. Also, ISI and FSS was evaluated at 1, 3, and 6 months as well. Power was set at 80%. Each arm needed 253 individuals to complete the study to meet. But like I said, since this is kind of a sub-study, there were only 61 total individuals. So there was no way they were going to hit that 3-leg criteria of 253. So power was not met. Alpha was also set at 0.05. The kind of to go over the data, the SOL was used with, so they were all used with a mixed effect repeated measures. And then they were also looked at with either a LSM or a LSGM. SSOL was looked at with a LSGM. WASO was looked at with the LSM. TST was looked at with the LSM. SE was looked at with the LSM. ISI looked at with the LSM, and FSS with the LSM as well. I all found these to be appropriate and effective at analyzing each of these outcomes. So to go over the results, the SSOL significantly improved over 6 months compared to placebo. We can see that because placebo had a drop of 23.2, 5 milligram group had a drop in 22.8, and then 10 milligram group had a drop in 32.1. STST significantly improved over 6 months compared to placebo. Placebo had 67.1, 5 milligram group had 97, 10 milligram group had 100. SSE also significantly improved over 6 months compared to placebo. Placebo had 14.2, 5 milligram group had 16.6, 10 milligram group had 17.7. However, you'll notice that there was only 3 of those outcomes that were on there, when in total there were 6 outcomes. So only 3 out of 6 outcomes improved. So they did not classify this as a effective because we only had 3 outcomes that improved. The other ones did not improve. Some of them actually had the placebo outperforming the independent groups. So again, since there were many outcomes that did not improve, as far as tolerability, this is a generally well-tolerated medicine. It's been out for a while now. It's kind of just a restudy. So a lot of the times, from what they saw in this study, the placebo had more adverse events than our LEM treatment groups. So fall percent were higher in placebo, dizziness higher in placebo. The total adverse events experienced throughout the whole 6 months were 81% in placebo, 71 in the 5 milligram group, 54 in the 10 milligram group. The main thing that was kind of noticed in the higher milligram group was a higher dizziness and tiredness. So the author's conclusion was that lemborexant improved sleep outcomes in individuals with insomnia disorder who are also being treated for depression or anxiety with no new safety concerns. However, a greater placebo response in this subpopulation reduced the observed treatment effect size. And again, they said the higher placebo response because in the 4 other outcomes, it did not improve. Actually, might have got worse. So they ruled it as non-effective, even though you had the 3 outcome that were effective. So as far as strengths, it was statistical tests, inclusion criteria, exclusion criteria, evaluation measures, randomization, blinding, and dosing. Limitations were power, sample size, high placebo response. As far as level of evidence, I concluded that it was level 2 with major limitations, the major limitations being the small sample size and the lack of power being met. And again, that goes down to the subpopulation being studied. So my overall recommendation for this is that lemborexant may be a suitable option for treating insomnia in select patients with mild depression or anxiety symptoms. However, further studies with larger sample sizes and better powered analysis are needed to confirm the findings. And I said select patients because, again, we only had partial outcome improvement. Some outcomes were not touched, some outcomes got worse. So I would not recommend lemborexant in the majority of patients with insomnia and dealing with mild depression or anxiety as a first option due to efficacy of these outcomes. And again, the outcomes that did improve were SSOL, SCST, SSE, but SWASO, ISI, FSS did not improve. Like I said, it's pretty well tolerated. No additional safety concerns. And well tolerated. Placebo experienced 81% adverse events. 5 milligram group experienced 71%. 10 milligram group had 54%. It is available only as a brand name, so it's pretty expensive. Lexicomp had it priced at $14.10 per tablet for either 5 or 10 milligrams. So probably going to need to get a prior authorization to be covered by insurance. There is no information available on the effects of lemborexant in pregnant women, and it has been shown to be present in breast milk. Also, older adults have a higher incidence of dizziness and tiredness, so it should be avoided in pregnant, breastfeeding, and geriatric patients. So that concludes my Journal Club 2. If you have any questions or concerns, you can shoot me an email, and I'll try to get back to you in a reasonable time. Thank you.